we kind of split up this presentation today. It's about 50-50. I'm going to go over some hospital-related items that I think some of you would be benefit to kind of go over today, as these are some relative changes that are coming up. Just to kind of get an idea here, if you are a PPS hospital, raise your hand. Do we have critical access here? Fair amount, large amount of critical access. And then Meranda is covering some rural health clinic topics. Do we have any hospitals with rural health clinics? Got a few too, okay. So the topics I'm going over today kind of focus on some of the Transmittal 18 CMS changes that have come out. These are effective for cost reporting periods that are 10/1/2022. So that would be any 9/30 year ends would be the first impacted by these. Some of these are more specific to PPS reimbursed type hospitals. Some of this though does impact some components of critical access as well too. So just going to go through this today. That is us. I'm going to move ahead here to kind of just the overview of what we're going to cover and go over some Medicare DSH reporting changes, compensated care, bad debt, Medicare bad debt changes, and then some other reimbursement changes that are coming up as well, followed by Miranda's rural health clinic presentation. So we'll just kind of jump right into it. If we're going through, if you have a specific question, you can, I'm fine with asking as we go through, or we can kind of save for some questions at the end. So first up, Medicare DSH. So with Transmittal 18, the new requirement is essentially hospitals that get reimbursed on a DSH calculation percentage. So uncompensated care, DSH payment, has a requirement to now disclose on a new exhibit their DSH Medicaid eligible days. For those of you that are here that get reimbursed on this, I'm pretty certain that most, if not all of you, look very closely at your eligible days, as that calculation plays an important role in your reimbursement. It's also an area that is a area of audit focus by the intermediary. So that's kind of what's caused this change, is more or less the area that might be getting sampled as far as DSH day reporting has historically gone, is now a required component of the filing of your cost report. And along with that, there's a new template. I have an example here of the template. It might be kind of small on the screen. I mean, I even need it. Even tough to see on my laptop here in front of me. But essentially, I think a lot of this is information that if you are tracking DSH days already, you are likely also already tracking. There could be some components here, though, that in your current tracking, you might want to just take note to, as some of these are changes that could be relative that you're going to have to start reporting. A lot of this focuses around just tracking the patient information. I'd actually jump ahead here to kind of some of the key takeaways. Basically what it comes down to is kind of disclosing the Medicaid number, state plan, is this restricted, unrestricted type of Medicaid day. One kind of unique reporting thing that is occurring here is if there is a labor delivery type of stay, mom's in the hospital as long as a newborn baby. As long as the mom's in the hospital, the reporting of those newborn days essentially stay on, I'll back it up here, the same line as the mom's length of stay period. Once mom's discharged, the baby gets their own line record if the baby remains in the hospital, has additional days. For the most part, the information is, I think, pretty straightforward. One new item that is asked for is the state eligibility code. That's why I've kind of just put a definition in here. I have not personally seen really good examples of this other than kind of just the instructions and some of the guidance that's out there. But essentially, any state plan should have an eligibility code, and tracking that code might be something new that's required on this form. And I believe it's more than just indicating this is a Title 19 day. The last area is there's a column regarding restricted and unrestricted types of stays. So there's some codes here that I just included for reference. The other thing that kind of goes along with all these forms is subsequent to this, but it lines up quite well, is the MCREF system. So this is the electronic filing side of Medicare cost report reporting. Has also issued some template forms that go along for electronic submission. I've included a link here, which basically is the template I showed here in their prescribed format that's used specifically for that uploading process. So I'm going to go ahead and move on here. Uncompensated care. So what we have here is the part of the cost report. Kind of again relates back to how DISH gets paid. So the S10 section of the cost report, those that are familiar, is where the hospital discloses uncompensated care, charity care, bad debt. The real major change that's coming here is historically all hospitals have completed this form and have completed the historic, what will be now Part 1, which is the entire hospital complex. There's now going to be a Part 2, which now really focuses on just the components that are billed under the hospital, inpatient and outpatient. So that would essentially, exclude like a distinct part unit that otherwise was included in Part 1. Along with this, there's some new forms that are also now required to be submitted with the cost report, which we're going to go over here shortly. A couple of just takeaways from this is when we talk about hospital charity care policy, one thing that has been somewhat, let's just say, clarified is CMS has indicated that it's the hospital's definition of what charity care policy is as far as what you're defining. Essentially, they can't say that an intermediary can define what should or should not be defined as charity care as long as it meets the hospital's charity care policy. Also, any patient charges that are covered under the COVID type of funding would also be excluded from this reporting. There's also a couple new lines, really just focus around insured or uninsured components have to be tracked. Here's an example of the uncompensated care reporting schedule. This is the new charity care specific component. Again, if you're already tracking charity care for this purpose, I think a lot of this information are components that you're probably already have in your system or you're tracking throughout the years as charity care is being deemed by the hospital. But if not, I mean, these are some areas of focus you might want to pay attention to. So the template for this, again, kind of follows suits as some of the audits that have previously taken place. Historically, intermediary would sample some of this information, and now thereafter you to provide all records at the time of filing the cost report. A couple kind of areas of takeaway here. I just defined what column 6 is as far as the patient coverage type, either insured but not covered, or uninsured. And then I also kind of included a kind of key calculation here for what charity care write-off would be based upon this form. I know internally we've kind of set up this formula so that when we work with a hospital and this information gets compiled, the calculation of charity care is essentially being done correctly, which is listed here as well too. There's no questions. I'm just going to move along here to compensated care. This is the bad debt form. Looks a lot like the uncompensated care form. Again, this is now tracking your total bad dets within your facility. Let's go over a couple key components here. Again, this is total bad debt for the hospital. The format really mirrors a lot of what the charity care schedule has shown. Came up with kind of what the calculation of bad debt from this form should be calculated, as well as I've included a link here as far as where these forms can be obtained from CMS. Here's one that's going to apply to all hospital types. So if you are a subset of a hospital provider number, I'm going to say that this change applies to you. This has been a known change that's been out there for a while, but this is now more or less the effective period. So cost report periods beginning on 10/1/2022 or thereafter. And this is the updated Medicare bad debt form. Traditionally, this was a 10-column form that has now been expanded to 24 columns. So a lot of the information that is being asked for is still very similar as to what was previously being asked, but it's essentially asking for some further detail along that information. One of the key differentiations here is there's now a number of write-off date columns. So that's your columns 14 through 17. Here, so I can actually see this. So they're now asking to track the accounts receivable write-off date, the sent to collection agency, yes or no as far as that goes. Then they want to know if it was sent to collection, what was that date returned, what was the collection effort cease date, and then finally, what was that Medicare write-off date. So all those dates are now important to be tracked separately. It is possible that some of those, the same date could be applied to all those columns, but I think in a lot of instances, you're going to have different dates for some of those. Again, the requirements for Medicare bad debt have not changed. It's still the same. Essentially, there's three paths to a bad debt. The easiest one is the crossover type bad debt. We have your traditional bad debt. That's something that the hospital has made a collection effort on for at least 120 days. And then the third type would be a charity care type write-off bad debt. So I'm going to go ahead and move here to just a couple of the items here. As I said already, this is expanded from 10 to 24 columns. There's some new date ranges that have to be identified, and then kind of the key calculation here as far as determining that allowable bad debt is essentially the co-insurance components from column 21 and 20, less any form of payments, which would equal that. I'm going to go over some of the additional reimbursement changes that are out there. I don't know if this would apply to many. Was a modification in this transmittal regarding GME. I believe this is specific to just a calculation correction of what that FTE cap is. Along with this, this is also already known as, I'm actually just recently this week been getting approval letters come through for this, is the extended low volume and Medicare dependent hospital programs are now extended through 12/31/2024. So these are, the request for that period is actually already passed us, but this is has been extended. One other kind of key change too is, if you're a hospital that had taken advantage of the additional beds set up under the health emergency period there is now a requirement to track those patient days associated with expanded beds separately. So, I'll give you an example here. If you're a critical access hospital with, let's say you had all 25 beds currently set up that you're allowed, and you had the availability to set up 5 additional beds during that period, they're now looking for you to track those days separately, and it's by payer type. And I think the key takeaway there is that when we break those days out, I'm assuming that the calculation, although I haven't verified this, is still looking at your total days that you're disclosing as far as your cost per day calculation goes, but you just want to make sure that this breakout takes all that into consideration. You're not artificially increasing your days more than you should be. So that's going to bring us to a couple other upcoming changes that are out there. Probably not going to be anybody here, but I don't know if there's any rural emergency hospitals in the attendance here today. Transmittal 20 came out, which was kind of specific to the cost reporting requirement and form updates that are specific to that. So that's effective for cost report periods 4/1/2023. One thing that has not really been clarified, or as far as what I have seen, is also during the pandemic there was a waiver for critical access hospitals as far as the conditions of participation with meeting an average length of stay of 96 hours or less. During the pandemic, a lot of hospitals had exceeded that. Some of these hospitals are the type of hospitals, I guess, that have always been close to that threshold already, and now they're over it. But what I've not seen is essentially any sort of ruling in terms of how that's going to get rectified as far as a partial year. By partial year, I'm looking at 2023 when the pandemic period ended, which tells me you could have a length of stay before that beyond 96 hours, but after that, the original requirement comes into play. So there's probably some ways internally that we should be, looking and tracking that information. But that's just something to know. If your hospital's been over that length of stay requirement, you might need to look and see how you're doing after May 11th in comparison. Also listed here a few MCREF changes that are coming up. Maybe one of the biggest ones that been promised for a while, but I've yet to see is interim rates, tentative settlements, things like that come through the MCREF system. So the advantage to this is at any time, if you want to go and take a look at a tentative settlement letter that was issued during the year, you'd have electronic access to that at any time. So once that rolls out, last I read it was supposed to be effective July 2023, but I've still yet to see that populate in the system. Lastly, if you're a rural health clinic here in the audience, this would pertain to a freestanding rural health clinic, so not a provider-based. There's been a slight change to the bad debt form. I'm going to go ahead and over that here. Which I don't have an example of the form here, but essentially it's expanded from the 10 columns to 12. Again, there's also an MCREF compatible version of that existing form that's available out there. So with that, I'm going to turn over the presentation to Meranda. Perfect. Here.
Don't have to hold that. Not as tall as Erik. All right. Can everyone hear me okay? All right. Awesome. So let's see here. My bearings. All right. So Erik went over the hospital updates, and I'll wrap us up with the rural health clinic updates, talking about some of the changes with the Consolidated Appropriations Act of 2023, some changes that occurred as a result of the public health emergency ending, and going into some of the 2024 proposed regulations. So I'm sure a lot of us are already aware, but the 2020 Census Bureau removed that non-urbanized definition of what constitutes a rural location. Thankfully, CMS has provided some interim guidance until something more permanent is put into place. So I know this sent a lot of rural health clinics and other rural facilities into a state of panic, but for the interim, CMS is allowing clinics seeking RHC designation or any clinics that are looking to move their physical location or do a change of ownership. You can meet this rural location either by the 2010 Census Bureau if you meet that non-urbanized or urban cluster definition, or based on the 2020 census if your clinic is located in an area that is not considered urban. So to put this into simpler terms, as long as your clinic is located in an area of 50,000 people or fewer, you'll meet this rural location requirement and you should be good to go. Another important thing to keep in mind, though, is you really want to make sure that your HPSA is still intact. A lot of HPSAs have been proposed for withdrawal, and this process has been delayed and delayed again, but it is set to be put into effect as of January 2nd, 2024. So if you're not sure whether your HPSA has been proposed for withdrawal, I highly recommend looking up the HPSA Find tool online to look up your county and your state. Yeah? A HPSA is a health professional shortage designation. So it is something that you do need to have in order to become a rural health clinic. So as long as you have your HPSA intact, you're good to go. But even if your HPSA is being proposed for withdrawal and you're not physically moving your existing RHC or doing a change of ownership, you'll be good to go. You won't be at risk for losing your RHC status. So before you do any of those changes, highly recommend looking into that. All right, going into the Consolidated Appropriations Act of 2023, something really exciting is that CMS is recognizing 2 new RHC provider types, which are marriage and family therapists and mental health counselors. This is coming into effect as of January 1 of 2024. And this is really exciting because CMS has not added any new RHC providers in decades. So this offers a lot of opportunity for rural health communities as far as the behavioral health world goes. So with them being an RHC provider, they'll be able to get paid at their all-inclusive encounter rate, just like any other RHC provider. However, the important thing to keep in mind is that just because CMS is recognizing them for Medicare purposes, it does not mean that our state is going to recognize them for Medicaid purposes. So as it stands, I believe Washington and Alaska aren't currently recognizing these, and I'm not sure if they have plans to do so. So we'll definitely want to try and talk with our state contacts about getting them added to the list. All right. So we all know the PHE ended on May 11th of this year. CMS gave quite a bit of flexibility with rural health clinics and some of those requirements that we typically must abide by, but they did provide some waivers during the pandemic. So first one listed here is that it's a requirement to have a nurse practitioner, a physician's assistant, or a certified nurse midwife available to provide patient care at least half the time the clinic is open. This requirement was waived during the pandemic, but now that the pandemic is over, we no longer we have to abide by this requirement now. Another opportunity that CMS granted during the pandemic was the ability to add a temporary location to our RHC during the pandemic. So we were able to provide Medicare services to Medicare patients during the pandemic, even if this temporary location did not meet the requirement of a rural health clinic. We were able to see patients and still bill at our all-inclusive encounter rate. Now that the pandemic is over, we can no longer have this temporary location, so we want to make sure that we are providing services within an RHC defined space now. For critical access hospitals with a provider-based rural health clinic, we do have to meet that 50-bed or less requirement. So in order to get paid our grandfathered RHC rate, so During the pandemic, we did not have to meet this requirement, and we were still able to be paid our all-inclusive encounter rate that was our grandfathered rate. Now that the pandemic is over, we do have to meet this requirement. If we aren't meeting this requirement of 50 beds or less at our hospital, then it doesn't mean that we're losing our RHC status, but you will have to revert back to the federal caps, which were placed in effect in 2021. So in 2023, that federal cap is $126. So if you have a grandfathered rate that's considerably higher than that, you'll want to make sure and meet that requirement. Also, during the pandemic, CMS allowed RHCs to provide home health nursing visits without the home health shortage area designation. Outside of the pandemic, pre and post-pandemic, we do need to have this home health shortage area designation to provide these services, to furnish and bill at our all-inclusive encounter rate. Digital evaluation services were also allowed to be offered during the pandemic, but now that the pandemic is over, we're no longer able to provide these services as they're no longer a part of that definition of that code G0071. All right. Also in the Consolidated Appropriations Act of 2023, as of the pandemic coming to an end, we are still able to provide distant site telehealth services through the end of next year. So just because we're still able to provide these services, we're not necessarily getting paid our all-inclusive encounter rate, but will be paid at the lesser of fee schedule or the actual charge. During the pandemic, telehealth services were not required to be provided through a HIPAA-secure technology. However, that's ended with the pandemic, and providers had 60 days to get into compliance with that. With the mental health distant site telehealth services, I'm sure most of us have heard that RHCs now permanently have the ability to provide mental health telehealth visits effective January 1, 2022. So this is really exciting as telehealth continues to expand. We're able to provide these services and get paid at our all-inclusive encounter rate. And now that MHCs and MFTs will be RHC recognized providers starting next year, they'll also be able to provide these services as well. So Medicare has not given any guidance as far as where the provider has to be located during these telehealth visits. So keep that in mind. That does offer some flexibility with providers, and sorry, I didn't change that one over. They don't have to be necessarily located within the RHC to provide these services. Typically, in order to have a mental health telehealth visit, the patient must come in and see a mental health provider 6 months before furnishing these mental health telehealth visits, but that requirement has been waived until the end of next year. So keep that in mind as well. Yeah. And these slides, I believe, will be available on the app too as well to download. Yeah. All right, now I'll go into the 2024 proposed regulations that pertain to rural health clinics. So as I mentioned, with MFTs and MHCs being two new RHC recognized providers, CMS is wanting to add some clarifying guidance as to what constitutes an MFT and an MHC, and also including verifying that they can receive that all-inclusive encounter rate as an RHC provider. CMS is also proposing that MFTs and MHCs have a little bit more flexibility with the experience requirement. So currently, as it stands with the Consolidated Appropriations Act, MFTs and MHCs must have 2 years of a postmaster's supervised clinic experience, but with this proposed regulation, they're suggesting that they have a little more flexibility and have either 2 years or 3,000 hours of that postmaster's supervised clinic experience. And that's mainly because each individual state is going to have their own requirements on what experience they must have. So CMS is just proposing this in effort to align with different states. In addition, addiction counselors that meet the requirements of a mental health counselor can enroll in Medicare as a mental health counselor. So that also opens up some opportunities for different types of services that we can provide in an RHC. MFTs and MHCs, CMS is proposing that they have the ability to provide services under G0323 and bill for such services under G0511. This is mainly just to remain consistent with other behavioral health providers like clinical psychologists and licensed clinical social workers, just to remain consistent with how those are already furnished and billed. Right. In another regulation that CMS is proposing is that they're suggesting that RHCs, among other rural facilities, have the ability to provide the intensive outpatient program services. So this would be new to RHCs, and IOP services are essentially a behavioral health service for patients with an acute mental health illness, such as substance abuse, schizophrenia, and others. And this is really intended for patients that require a higher level of service than an outpatient visit with a mental health provider. If enacted, the IOP services, it would require the physician to certify the patient's needs for at least 9 hours, but less than 19 hours a week. The patient's plan of care must be documented at least every other month and includes other specific requirements laid out in the guidelines. Also, if enacted, this would be in effect as of January 1, 2024, and the proposed payment would be $284 a day. So with that, this wouldn't constitute an RHC encounter. So for Medicare cost reporting purposes, they would need to be carved out of the cost report and most likely carved out down to a non-RHC cost center, and we would need to make sure that those visits are carved out on Worksheet B as well. All right. As it stands currently, RHCs already have the ability to provide remote physiologic monitoring and remote therapeutic monitoring services, also known as RPMs and RTMs. This proposed rule is simply just proposing that if we provide these services, that they're billed at a rate outside or at a fee outside of the all-inclusive encounter rate. As it stands currently, if these services are furnished included in an RHC visit, that payment is included in the all-inclusive encounter rate. So if this goes through, then these services would be reimbursed within the Care Management Code G0511. One limitation with this, though, is that with Care Management Code G0511, you can only bill for this Care Management Code once per month per patient. So, for example, if you're already providing chronic care management services to this patient and you see them also for an RPM or RTM service, you can't also bill for them for that service under G0511. So if this is enacted, CMS would need to provide additional guidance as far as how that billing would go and what that would look like. CMS is also proposing community health integration and principal illness navigation be paid through the G0511 code. And in addition, with the G0511 code, the methodology for this payment is currently taking the average of all the codes billed under this care management code, and that's what the payment is, which is $77.24 in 2023. However, with this proposed regulation, they're suggesting that we instead use a weighted average utilization for the payment. So if enacted, this would be a fee of $72.98, which is obviously a slight decrease from 2023. All right, another proposed regulation that CMS is putting out there has to do with the certification requirements in the definition of a nurse practitioner. So as it stands currently, a primary care nurse practitioner must be certified by the American Nurses Association or by the National Board of Pediatric Nurse Practitioners and Associates. So in this proposed definition, they're essentially wanting to open that barrier a little bit and include other national certifying organizations. So with nurse practitioners being one of the faster growing provider types in rural areas, this is pretty important, and I feel will open the barrier for nurse practitioners to offer care to patients in rural areas. So I will wrap us up real quick with a hot topic that we've seen become more emergent. So with FQHCs, and I'm not sure if there are any in the room, but with FQHCs, they are eligible to get paid the difference between Medicare and Medicare Advantage payments. They're made whole through the RAP reporting process. And additionally, for services billed with the Revenue Code 519, they're able to contract with their MA plans at a 519 rate, and that's something that WIPLE has actually been helping FQHCs with across the U.S. We're finding a lot of FQHCs aren't aware of this, so if that's something that you're not sure about, definitely reach out and we can help out with that process. Unfortunately, on the other hand, for rural health clinics, we're not able to contract with the MA plans because they are, well, not at our RHC rate, because MA plans are considered commercial plans. So the National Association of Rural Health Clinics, also known as NARC, they've been noticing this great uptick in beneficiaries enrolling with Medicare Advantage plans in rural communities. So they're really doing a lot of research and exploring opportunities where maybe we can get something through Congress to identify solutions and get contracted, whether it is at our RHC rate or at some other minimum rate per encounter, or even a RAP reporting process. So this is something that NARC is taking a look at, and it is a long-term battle, but they do see it as a really important issue. NARC has actually reported that 13 years ago in 2010, 11% of eligible rural beneficiaries are enrolled in a Medicare Advantage plan with 9 plans to choose from. And today in 2023, that statistic has increased to 40% of eligible rural beneficiaries that are enrolled with an MA plan and 3 times as many plans to choose from. So I also want to preface that this isn't necessarily specific to Washington and Alaska, and it may even look different in your community, but this is something that they've reported that they've seen an uptick across the rural communities across the United States. So it is undeniable that it is increasing over time, and they do see it as a serious issue. So they are taking a look at it, and hopefully we see something come out of the works for this so that we can get additional reimbursement in our pockets from Medicare Advantage plans. So that was everything that we had, and we'll open it up for questions.